our honorable faculty and EDIC Part 1 aspirants. Let's commence our today's EDIC Part 1 class. Today's topic would be infectious and immune disorders. It is such an honor for us to have you today between us, sir. He is a consultant in infectious diseases at Apollo Multispecialty Hospital in Kolkata. His area of interest are as follows: infection in immunocompromised host, device associated infection, tropical medicine, antimicrobial resistance, antimicrobial stewardship, and infection control.
Thank you, Farz Academy, for this kind introduction and this opportunity. So today's topic of discussion is infections and immune disorders. I am an infectious disease physician, but I'll cover these two topics together because these two topics are quite, they're interconnected, and some of the infections will trigger immune disorders, and some of the immune disorders will require steroid or other agents which will invite the infections. So over the next 45 minutes or so, I will be going through this basics of immune disorders. I will not go into much of the details of basic physiology or pathology, but the basic concepts of immune disorder I will elaborate, and different immune disorders like autoimmunity as well as the immunodeficiency disorders I will talk, and then some cases, and I'll invite others on the audience to actively participate in this case discussions, and they can write their response in the chat box. Some of the infections, general and opportunistic infections, some infections we see in our day-to-day practices. I have just put those cases and not much complicated cases. What is the impact of immune disorders of infections, and at the end, take-home message. This is mostly a didactic lecture, but I'll invite others to make it slightly interactive so that it becomes more interesting. So immune disorders can be classified broadly into two groups. It could be immune dysregulation or could be immune deficiency. The immune dysregulation is the autoimmunity or autoimmune diseases. Autoimmune diseases will be caused by autoimmunity when there is a cell damage by autoimmunity. So not all autoimmunity will cause the disease. Mere autoimmunity is the presence of antibodies against the antigens or the presence of T cells against the self antigens. When it will cause the cellular damage, then it will be called as autoimmune disease. Whereas immunodeficiency, it could be primary immunodeficiency, that is defect in the adaptive immune system or in the innate immune system or in the immune regulations, or it could be acquired immunodeficiency by some triggers like infections or some immunosuppressive agents. I will not discuss HIV in this talk because in my last talk I have already elaborated HIV related infections. So I'll elaborate some of the primary immunodeficiency and some of the acquired immunodeficiency in special hosts like transplant recipients. So what is the mechanism of autoimmunity? How it occurs? Sorry, there's a lot of noise. Yes, thank you. So mechanism of autoimmunity, how it happens, it occurs due to exogenous stimulus or endogenous or increased T cell or B cell response, or it could be due to cytokine imbalance or altered immunoregulation. What is a molecular mimicry? When a superantigen stimulation or a virus or a bacterial antigen will enter into the body, that may act as a antigen that looks exactly like the self antigen, and body will create non-specific antibodies, and that will cause the cell damage. That's how the exogenous stimulus will be causing the autoimmunity. Again, there are a lot of mechanisms for endogenous stimulus, but the main point is there will be alteration of the self antigen, or there will be increased cytokine production at the end and will cause this kind of autoimmunity.
Sorry to disturb you, hello, but your slides are not changing. Or you are.
Yes. I'm in a mechanism of autoimmunity. So it can happen by exogenous stimulus or endogenous, or increased B cell or T cell responses or cytokine imbalances. How the tissue damage happens? It could be due to autoimmunity or by T cells. Autoimmunity can block or stimulate or can help in opsonization or can cause direct cellular cytotoxicities. Like in case of antiphospholipid antibody syndrome, there will be blocking of the phospholipid B2 glycoprotein 1 complex. So there will be this disease. Again, myasthenia gravis can be caused by blocking of the alpha chain of nicotinic acetylcholine receptors. In case of granulomatosis with polyangiitis like Wegener's granulomatosis, there will be stimulation of the ANCA ANCA or the proteinase 3, where all these autoimmune or vasculitis will happen. Again, some opsonization defects will cause autoimmune thrombocytopenic purpura, whereas for T cell, it is mostly due to cytokine productions. Cytokine production will cause rheumatoid arthritis, multiple sclerosis, and type 1 diabetes mellitus. Also, cellular cytotoxicity can cause type 1 diabetes mellitus. You can see in rheumatoid arthritis, there is also antibody response and also T cell response causing this disease. So there are a lot of overlap between two effector mechanisms. What is important is for a clinician when to suspect an autoimmune pathogen. Whenever there will be a presence of autoantibodies or there is evidence of some cellular reactivity to the self antibodies. Whenever there will be documentation of relevant antibody or some lymphocyte infiltrate in the pathological tissue, that is the histopathological proof. And third one is the demonstration of the relevant autoantibody causing the T2 tissue damage. It could be by transplacental transmission or by adaptive transfer into the animals or in vitro cellular impact. The supportive evidence can be reasonable animal model or a beneficial effect of immunosuppressive agents, or there is an association with the evidence of autoimmunity, or there is no evidence of infection or other obvious cause and that is responding to immunosuppressive agents. This is how we get the supportive evidence and we suspect the autoimmune pathogenesis. The disease when happens, it could be organ specific or non-specific. Now, organ specific disease I have already discussed. It can affect the pancreas and cause diabetes. It can affect the thyroid, can cause Hashimoto thyroiditis or a Graves disease, or it can involve the neurological tissues like it can cause multiple sclerosis and pulmonary syndrome. Whereas non-specific or systemic autoimmune diseases are most important. They are SLE, rheumatoid arthritis, systemic necrotizing vasculitis, Wegener's granulomatosis, Apollo syndrome, and Sjogren's syndrome. I'll not go into detail of all these diseases, but I'll elaborate whatever is needed for ICU admissions or intensive care. So this is a case, 76-year-old male, hypertensive, had a paroxysmal atrial fibrillation and was on anticoagulant, had a reflux disease and anemia of chronic diseases, came to the emergency with complaint of abdominal pain and nausea for 4 days. So it's an acute onset abdominal pain and nausea. Lab-wise, had low hemoglobin and increased creatinine. His CT abdominal pelvis was done, which showed edema and streaking of the gastric antrum, which was consistent with the antral gastritis. But there was rapidly worsening of the kidney function, and renal biopsy showed there is dysenteric glomerulonephritis, which is consistent with the RPGN, that is rapidly progressive glomerulonephritis. A transthoracic echo was done, and they revealed that there was a left atrial thrombus also. The patient required hemodialysis for this worsened kidney function, but soon after this hemodialysis, patient started having shortness of breath with hemoptysis. So what do you think? What is this syndrome or what is this case happening here? There is rapidly worsening of kidney function and presenting with abdominal pain followed by shortness of breath after this hemodialysis along with hemoptysis. So two organs are mostly involved. One is lung and one is kidney. So what is the syndrome that may be related to the autoimmune disease? Any responses, please? You can write your response to chat box or you can interact directly. Okay, so some responses I got in chat box. Woodpastu syndrome, Wegener. Okay, so whenever we approach a case like this, we should always think what are the organs involved. Here the pulmonary and renal involved. So there are a lot of diseases that can cause this pulmonary and renal syndrome. Yes, Woodpastu can cause, Wegener's granulomatosis can cause, but we will make it like a syndrome and we'll call it as a whole pulmonary renal syndrome. then only the approach will be correct. So this is a pulmonary renal syndrome. What is a pulmonary renal syndrome? This is a combination of the two entities. There will be diffuse alveolar hemorrhage. For this patient, it presented with hemoptysis, and there will be a rapidly progressive glomerulonephritis. So, as you can see, there are a lot of causes of pulmonary renal syndrome, right from the ANCA-associated vasculitis and also cryoglobulinemia, rheumatoid arthritis, SLE. Everything can cause pulmonary renal syndrome. There are some of the entities that can cause isolated diffuse alveolar hemorrhage, like idiopathic pulmonary hemosiderosis, isolated pulmonary capillaritis, also some other non-related diseases that are very important to rule out, like infective endocarditis, radiation pneumonitis, ARDS, particularly in the setting of coagulopathy, mitral stenosis, and acute interstitial pneumonia. This can cause isolated diffuse alveolar hemorrhage. So whenever we get such cases, approach like a pulmonary renal syndrome, then we will not miss these vasculitis cases. How to investigate? Investigations are very usual, common investigations. Send for this complete blood count and hemoglobin platelets, do the basic coagulation test, blood smear to see the cystocytes or the microangiopathies, look for the kidney function, do the creatinine and burn, and also do urine analysis and urine sediment assessment. Blood and urine cultures are very important because we need to rule out infections. Infections are the great mimickers. I'll always say this. So do blood culture and urine culture. Good volume blood culture is a must. Serologies like including the ANA, ANCA, anti-GBM, and also rheumatoid factor and anti-CCB antibody will help for diagnosing this case. A chest radiograph or a CP chest will reveal this diffuse alveolar hemorrhage. Sometimes flexible bronchoscopy is done and bronchoalveolar lavage is done, and that pulled up blood is drawn out. But usually that lung biopsy is not necessary to diagnose pulmonary renal syndrome. What we need is a percutaneous renal biopsy, because without a histopathology, we cannot tell that this is an RPGN. How to treat? We have to treat the underlying condition. If there is infection, treat the infection. If there is autoimmune disease, then treat that. But before treating autoimmune disease or increasing the steroid dose, must rule out the active infection. If there is no infection, maybe we have to pulse with steroid, 3 doses of methylprednisolone of 500 to 1 gram, 500 to 1 gram, 500 milligram to 1 gram. And at times, patient may need plasmapheresis or IVIG. There is some role of ECMO, but that is not well defined. So how to classify a vasculitis? Depending on the involvement of the vessel, it could be medium vessel or a large vessel or a small vessel. The vasculitis will differ. Whenever there will be involvement of the small vessel vasculitis, it could be immune complex deposition or it could be ANCA associated. So the entities differ, but the presentation will be the same as the small vessels like capillaries will be involved, and mostly the similar kind of presentation will come in. So how to define the clinical features of a vasculitis? Whenever there is a small vessel vasculitis, the small cutaneous vessel may be involved and may cause the palpable purpura. If the glomerular capillaries are involved, it will cause hematuria, red cell cast in urine, proteinuria. If the pulmonary capillaries are involved, there will be lung hemorrhage manifestations as breathlessness and alveolar shadowing in the chest radiograph. So it's majorly capillarities and involvement of the venules. Whereas for medium vessel vasculitis, there will be overlap between small and medium sized arteries, and it will mostly involve the mesenteric artery, epidural arteries, renal artery, coronary artery, and small pulmonary arteries. What is most important is necrosis could be seen in case of medium vessel vasculitis. If necrotic lesions are present, the skin and along with the ulcers and nail fold infarct, always suspect a medium vessel vasculitis. Like a polyarteritis nodosa, we can see this kind of presentation. For coronary arteries, patient may present with myocardial infarction or an angina-like presentation, or if the renal artery is involved, there could be renal infarctions. For a large vessel vasculitis, usually it involves the aorta or its branches. If the extracranial branch of the carotid artery is involved, patient presents with temporal headache, blindness, or a jaw claudication. We can call this a giant cell arteritis. If the thoracic aorta or its branches are involved, then Patient may have limb claudication, absent pulses, and unequal blood pressure. We can have bruit of a large renal artery buoy, or and have thoracic aortic aneurysms. We call it as a Takayasu syndrome. So coming to the next case is a 48-year-old man. He's an injecting drug user. Presented to us with a 4 weeks history of feeling unwell and purpuric rash all over the body. When he came, he was actually looking very ill, and he had several nail-fold infarcts, and there was a vasculitic like rash on his palm of his fingers. Blood picture was keeping in consistent with this systemic inflammatory response. Chest radiograph showed 2 separate cavitating lesions in the right lung. Skin biopsy was also done, which showed a leukocytoclastic vasculitis, and his illness was initially attributed to some systemic vasculitis, and specialist opinion was sought. So what do you think? This patient, injectable drug user, presents with this kind of presentation, having a leukocytoclastic vasculitis with nail infarcts and palpable purpuric lesions. So what could be the possibility? Please remember that the patient also had cavitating lesions in the lung. So what are the possibilities? Responses, please. You can write your response in chat box. So apparently this case looks like a vasculitis kind of presentation with a palpable purpura, but the history is for 4 weeks, and the most striking thing is he's an injecting drug user. So always rule out infection, as I said. So the response comes as infective endocarditis, vaginous granulomatosis, correct? So infective endocarditis is definitely a very good differential, and we should send good volume of blood culture. For this patient, so it's a vasculitis or not? Yes, there is a doubt of vasculitis. Always rule out the infections. The blood culture of this patient grew Staphylococcus aureus, and transthoracic echo revealed a vegetation in the tricuspid valve. So it's a right heart endocarditis, and that's why the cavitating lesions were there due to septic emboli. That's how infections are the great mimickers in this case. So what are the vasculitis mimickers and the secondary causes? Inflammatory diseases of unknown etiology like rheumatoid vasculitis, vasculitis associated with systemic lupus erythematosus or a Sjogren's syndrome. This can also mimic like vasculitis. Some of the infections like hepatitis B, C, HIV, mycobacterial syphilis can also present like this, or we saw this case of infective endocarditis, similar kind of presentation can come. Neoplasia, some of the neoplastic disorders like hematological malignancies, myeloproliferative and lymphoproliferative disorders, and some of the solid tumors will be having vasculitis like presentation. And almost all the drugs can cause vasculitis. So we should be very careful while diagnosing a vasculitis. Rule out this, get a proper history, and then go for a diagnosis and treatment. Here I'll just elaborate these 3 entities associated with ANCA. What is more important is for vaginal granulomatosis, the ANCA positivity will be highest, the 80 to 90% of the ANCA positivity. Whereas for eosinophilic granulomatosis with polyangiitis, the ANCA positivity is only 50%. And percentage of positivity of P-ANCA will be more for microscopic polyangiitis and eosinophilic granulomatosis with polyangiitis rather than GPA or vaginous granulomatosis, where C-ANCA positivity will be more. Pulmonary hemorrhage will be common in all 3. Microscopic polyangiitis can present with isolated diffuse alveolar hemorrhage. Ophthalmological involvement will be more in case of vaginal granulomatosis. It is rare in other 2 entities. Cardiac involvement also is rare for granulomatous polyangiitis, granulomatosis with polyangiitis, or microscopic polyangiitis. But for EGPA or eosinophilic granulomatosis with polyangiitis, myocarditis can be seen. Pathology wise, everybody will show leukocytoclastic vasculitis, but for vaginal, there will be granuloma along with leukocytoclastic vasculitis. Whereas for EGPA, along with leukocytoclastic vasculitis, there will be eosinophilic granuloma or infiltrate. So this is how we differentiate clinically and then pathologically, and then we plan for therapy.